Hello, my name is Osama Naga. This presentation is focused on the clinical approach to a child with headache. My objectives in this presentation is to understand the evaluation of a child who has headache, recognize the diagnostic criteria for pediatric migraine, recognize red flags for elevated intracranial pressure or other underlying conditions in the child who has headache, discuss treatment strategies for migraine, tension, and chronic headache disorders. This presentation is a supplement to the neurology chapter in the Pediatric Board Study Guide. Clinical approach to a child with headache. The first and most important question we have to ask, is it acute or chronic headache? Detailed history and focused physical examination is the most critical step in the diagnosis of headache in pediatrics. Migraine, ask about family history of migraine. This will be very helpful. Ask about any signs of upper respiratory tract infection, for example, low-grade fever, runny nose, congestion, and cough. This can be associated with acute headache, and this is very common. Streptococcal infection can cause headache even in absence of fever, even in absence of throat pain. So look at any signs of inflammation of tonsil, petechiae in the throat, and send throat culture or rapid strep if you have any signs suggestive of a streptococcal infection or throat infection in general. Meningitis, encephalitis, the presentation will vary according to the age. Absence of meningeal sign, very important to know, does not rule out meningitis nor encephalitis. Stroke can be associated with acute onset of headache. Look in this history if the child mentioned or said, "This is the worst headache of my life." Trauma, tumor can be associated with acute onset of headache. It doesn't have to be over time, doesn't have to be progressive. Tumor can present with acute onset of severe headache. Malignant hypertension, vasculitis. If the headache is chronic, episodic, and recurrent headaches, the most likely causes are tension type headache, migraine with or without aura, recurrent sinus headache. Ask about allergic rhinitis. This can be associated with recurrent sinus headache. Seizure associated with headache. Ask about history of seizure or epilepsy, recurrent toxic exposure to alcohol, toxins, illicit drugs, medications. Overuse of ibuprofen or acetaminophen for a headache or pain in general. This can be associated with headache and is well known as analgesic headache. So detailed history is very important to make this diagnosis. Possible causes of chronic progressive headaches: elevated intracranial pressure, tumor, vascular malformations, infection, sinus, venous thrombosis, idiopathic intracranial hypertension or pseudotumor cerebri, endocrine disease, for example, thyroid or hyperthyroidism or parathyroid disease, Chiari malformation or vasculitis. Possible causes of chronic non-progressive headaches: chronic tension type headaches, chronic migraine, chronic sinus disease, dental disease. So it is very important to examine the teeth in any child with persistent headache. Sleep apnea, ask about snoring or difficulty breathing at night, idiopathic intracranial hypertension or pseudotumor cerebri, thyroid disease or hyperthyroidism, Chiari malformation, fasting and eating disorders. Very important to ask about nutrition and eating habits. Chronic post-traumatic headache, this can be easily obtained from the history. History is the most critical part in the diagnosis of headaches in pediatrics. These are suggestive questions to ask. When did the headaches begin? Was anything associated with headache onset? Are the headaches getting worse, staying the same, or improving? Are they getting more or less frequent? Are there any triggers for the headaches? What are the headaches like? Where is the pain located? Does the headache wake the child from sleep? Are there any other symptoms associated with the headache or warning signs that a headache is coming, which is aura? How long does the headache last? What makes the headache better or worse? Ask about lifestyle. Inadequate sleep or poor sleep can cause headache. Poor hydration, how many cups the child is drinking per day. Poor food choices, lack of breakfast, excessive caffeine intake can cause rebound headache. All these factors are simple to ask and they can cause headache. Family history is very important and critical in the diagnosis of migraine headache because of strong genetic component of migraine headache. Ask about any type of headache. Headache pattern often is different in different family members and also can skip generations. Social history is very important as well. Conflict at home, in school, sexual activity, pregnancy, drugs, physical or sexual abuse, bullying in school, depression, family finances and stress, alcohol use, and eating disorders. Physical examination is another critical step in the diagnosis of headaches in pediatrics. Check the height and weight, calculate the body mass index. High body mass index or children with obesity, they may suffer from headaches because of several factors. For example, obstructive sleep apnea, lack of sleep, depression because of bullying in school, temperature like in cases of infection. Check the blood pressure for hypertension or hypotension, heart rate for tachycardia like in cases of hyperthyroidism or bradycardia. Combination of hypertension and bradycardia is a red flag for increased intracranial pressure and has to be taken seriously. Check the respiratory rate for tachypnea, for example, like in cases of asthma or lung infection. General condition of the child is stable or unstable, interactive or not interactive, any signs of sadness or depression, malnourished or signs of pallor or anemia. Check the eyes for refractive errors because persistent straining of the eye can cause headache. Check the pupils if it's reactive to light and accommodations, if they are equal or not. Check the extraocular movements and any signs of strabismus. Any child with a new onset strabismus has to be taken seriously. This can be associated with intracranial mass. Check the ears for ear infection, teeth for tooth decay or dental infection, throat for throat infection like streptococcal infection or viral infection can cause headache. Check the neck for lymphadenopathy and palpate the thyroid for goiter or signs of hyperthyroidism. Check the heart for heart rate, murmur or signs of hypertension, lung for wheezing or pneumonia, abdomen for masses or constipation. Urine infection can be associated with headache, very important to keep in mind. Check the skin for signs of acne. Ask about oral intake of anti-acne medications, for example, doxycycline, minocycline, or oral vitamin A. These drugs, they can cause elevation of intracranial pressure and headache. Check the skin for any signs of neurocutaneous syndrome like ash leaf macules or hypopigmentation like in cases of tuberous sclerosis, cafe au lait spots like in cases of neurofibromatosis. Check the joint for range of motion, joint swelling, and possibility of association of rheumatologic disease. Focus the neurologic examination. Look for exaggerated reflexes and signs of upper motor neuron lesions. We always worry about brain tumor when we have a child presenting with headache. Primary cause of headache like tension headache, migraine are very common. Brain tumors are rare, but it's very important not to be missed. Brain MRI not routinely recommended to be ordered for a child with recurrent headache and normal neurologic examination because simply the likelihood the MRI will show abnormalities is very low. Indications for brain MRI if the headache is sleep related, absence of family history of migraine, headache less than 6 months duration or short duration, a child less than 3 to 5 years with recurrent significant unexplained headaches, confusion, abnormal neurologic findings, vomiting, headache associated with cough, urination or defecation, exclusively occipital headache or headache associated with neck pain, always abnormal, change in headache type, become progressive, increase in headache frequency or severity. This is a statement of the American Academy of Neurology practice. Obtaining a neuroimaging study on a routine basis is not indicated in children who have recurrent headaches and normal results on neurologic examination, simply because brain MRI requires sedation, can cause financial stress to the family, and psychological stress until they know the result. Neuroimaging study, on the other hand, should be considered in children who have abnormal results on neurologic examination and the coexistence of seizures or both. Brain MRI much more preferred than CT scan. CT scan is a good option if the child is unstable. We'll start with migraine headache. Migraine headache without aura is the most common in pediatrics. Characteristics of migraine headache: recurrent attacks, at least 5, headache attacks lasting 1 to 72 hours, unilateral location in one side, can be in both sides or frontal, but not exclusively occipital or in the back of the head. If any child with occipital headache only, you have to look for other causes, not migraine. Pulsating in quality, moderate or severe intensity can be really bad or severe headache. Aggravation by or causing avoidance of routine physical activity, for example, will be aggravated by climbing stairs or walking or exercise, or cause avoidance of exercise or walking or climbing stairs. During headache attack, at least one of the following: nausea and or vomiting. So migraine headache can be associated with nausea and vomiting. Photophobia, or phonophobia, or both together. So photophobia light sensitivity, phonophobia sound sensitivity, and is not attributed to another disorder. Migraine headache with aura is less common in pediatrics. So aura is visual or sensory symptoms start before or with the beginning of headache. It is fully reversible, usually lasts more than or equal 5 minutes and less than 60 minutes, in form of flickering lights, light spots, lines, loss of vision, feeling pins and needles, numbness, or speech disturbance. Clinical presentation of migraine headache varies by age. Migraine headache can present as early as during early infancy with infantile colic. If the colic is exaggerated more than usual, ask if the mother herself is having migraine headache. This can explain why the infant is suffering too much from infantile colic. In older infancy may present with head banging. In preschool age may present with irritability, crying, rocking, seeking a dark room. Also may present during preschool age with ill appearance, abdominal pain. If you have a child with recurrent abdominal pain unexplained in between attacks, the child looks normal, there is a family history of migraine, the most likely cause is abdominal migraine. Also may present with recurrent vomiting, cyclic vomiting, and in between attacks the child is acting normal. So if there is a family history of migraine and the child is presenting with recurrent vomiting unexplained, the most likely cause is cyclic vomiting or abdominal migraine. Also, the need to go to sleep or seeking a quiet place. 5 to 10 years of age, they are more verbal and they are able to specify the symptoms more. The pain may be bifrontal, bitemporal, or retroorbital headache, nausea, recurrent abdominal pain or abdominal migraine, cyclic vomiting, photophobia, phonophobia, or a need to sleep. Tension headache is the most common type of headache in childhood but is less disabling than migraine headache. The pain is usually mild to moderate. The pain may last for 1 hour or for several days. It is described as band-like pressure or tightening around the head, and the pain usually triggered by fatigue, illness, or stress. The patient may have muscle pain or tension, especially in the neck and shoulder. If the pain less than 15 days per month is considered episodic. If is more than or equal 15 days per month is considered chronic. Management of headache. Smart headache management is very helpful in most of the cases of pediatric headaches, especially if there is no identified underlying cause. Smart mnemonic: S for sleep, M for meals, A for activity, R for relaxation, and T for trigger avoidance. Sleep, regular and sufficient sleep is very helpful. Regular and sufficient meals including breakfast and good hydration. Activity, regular aerobic exercise is helpful but not excessive. Relaxation and stress reduction, trigger avoidance such as stress, sleep deprivation, or other identified triggers. Acute treatment of migraine headache in pediatrics. The first line is NSAID, for example ibuprofen, naproxen, or acetaminophen, but very important not to exceed more than 2 to 3 days per week because excessive use of analgesic by itself can cause headache. If the first step is not helpful, you can add caffeine. For example, soda, tea, or coffee. If this is not helpful, you go to the third step, which is triptan. The FDA approved triptan is rizatriptan between 6 and 17 years of age. Almotriptan for adolescents. Very important also not to exceed more than 10 days per month. So first line ibuprofen, naproxen, or acetaminophen by itself. If it's not helpful, you can add caffeine. If it's not helpful, you can use triptan, but not to exceed more than 10 days per month. Children with migraine, they may present with nausea and vomiting, also cases of abdominal migraine and cyclic vomiting. We have to provide medicine to help with the nausea and vomiting and also to prevent dehydration. Promethazine and prochlorperazine, they are dopamine antagonists and they are very helpful in nausea and vomiting. Ondansetron is less side effects, is well known as Zofran, however it is expensive. The dose is 4 to 8 milligrams every 8 hours as needed. If a very young child less than 15 kilo, the dose is 0.2 milligram per kilo per dose every 8 hours as needed. If is the weight between 15 and 30 kilos, the dose is 4 milligrams. If it's more than 30 kilos, the dose is 4 to 8 milligrams every 8 hours as needed. very important to know, antiemetic, they can cause sedation and dystonic reaction, and the treatment for dystonic reaction in general is Benadryl. Preventive therapy and the prevention of migraine headache in pediatrics. Consider preventive therapy for migraine if the headache is frequent enough to interfere with the patient's lifestyle, or if more than or equal 4 days of disabling headaches per month. Prophylactic therapy is not immediate. It will take time to see some improvement, as long as 8 to 12 weeks before improvement occurs. So it is very important to discuss with parents. The prophylactic medicine will not work immediately. It will take time to see some improvement, so they do not stop the medicine sooner. Then every 6 to 12 months, reassess the need for continued prophylaxis. So after initial visit, schedule a follow-up at 8 to 12 weeks, then reassess again between 6 and 12 months. Some parents may prefer to try natural supplements and vitamins before starting actual medicine to prevent migraine. Riboflavin, vitamin B2 can help, magnesium oxide, coenzyme Q10, and melatonin. So we have a combination here of 3 items. It's called Mega Relief, which is B2, or riboflavin, vitamin B2, magnesium, and feverfew. So 1 to 2 capsules per day, children's size, can be very helpful to prevent migraine. Coenzyme Q10 and melatonin. Melatonin is a good option for adolescent who has headache and has trouble sleeping. We have multiple medications we are able to use to prevent migraine in pediatrics. So which medication we should use first, depending on the comorbidity and the side effect of the medicine. For example, if you have an obese child or overweight, the best choice to use in this case topiramate. Why topiramate? Because this can cause weight loss. So the child will not be affected with the side effect of this medicine. But if this child himself or herself is having kidney stones or positive family history of kidney stones, topiramate or Topamax is not a good option, because one of the side effects of topiramate can cause kidney stones. If a patient is having asthma or diabetes or depression, propranolol is not a good option to use in this case, because propranolol can exacerbate asthma, mask the symptoms of hypoglycemia in patients with diabetes, and can cause depression. So it's not a good option to use in this case. If the patient is thin, it's a good option to use cyproheptadine or amitriptyline, because they increase appetite and they can cause increase in body weight. Cyproheptadine is antihistamine, antagonizes central and peripheral H1 receptor, so it has a sedative effect. The dose of this medicine 0.25 to 1.5 milligram per kilo per day, divide every 8 hours. The maximum dose is 12 milligrams per day. This medicine is approved to be used as a preventive therapy for migraine, also is used for allergic rhinitis, urticaria, and anorexia. The side effect of this medicine: sedation, dry mouth, and weight gain, because it increases appetite. This is the best choice for a child who has migraine and at the same time is thin, having trouble with appetite, or maybe having allergies as well, and insomnia or trouble sleeping. Amitriptyline is a tricyclic antidepressant, is another option to prevent migraine. The dose is 10 to 50 milligram at bedtime, once at bedtime, and start usually with the lowest effective dose and continue the lowest effective dose to prevent or to avoid side effects. Possible side effects of this medicine: sedation, weight gain, may exacerbate cardiac conduction defect, suicidal thinking, very important to inform the parents, and mood change. This is the best choice for a child who is active, thin, and is having trouble sleeping. Topiramate or Topamax is another option to prevent migraine in pediatrics. This medicine is anti-seizure medicine used for partial seizure and difficult cases of epilepsy. Start with the lowest effective dose. Start with the 25 milligram at bedtime and may increase the dose to 25 milligram twice a day to maximum 200 milligram per day. Side effects of this medicine: sedation, appetite suppression, weight loss, kidney stones. So it is the best option for a child who is obese with migraine and at the same time no family history or no history of kidney stones. Another option to prevent migraine is gabapentin. Side effects of this medicine: fatigue, ataxia, tinnitus, mood changes, and depression. Another option, valproic acid, is anti-seizure medicine. Side effects: weight gain, bruising, hair loss, hepatotoxicity, teratogenic, and thrombocytopenia. Generally, start with a low dose and gradually increase to the goal or effective dose to minimize the risk of adverse effects of these medications. Propranolol is a non-selective beta blocker used to prevent migraine as well. The dose is 2 to 4 mg per kilo per day. Side effects of this medicine: hypotension, depression, also may exacerbate asthma or bronchospasm, may mask also the symptoms of hypoglycemia in patients with diabetes. So it's not an option to use in these cases. This is the best choice for a child or adolescent who is performing low aerobic exercise and having postural orthostatic tachycardia syndrome, but is not a good option for a child who is competitive athletes because it may decrease their performance. Verapamil is a calcium channel blocker, is another option. Side effects of this medicine: hypotension, nausea, atrioventricular block. Is not a good option to use for a child who is having heart problem. This is the best choice if the child is having migraine and the blood pressure is in the higher side or is having hypertension as well. Treatment of unusual headache syndromes: typical migraine preventive medications can be used like topiramate or Topamax, tricyclic antidepressants, for example, amitriptyline. Complementary therapies like biofeedback, psychotherapy, physical therapy, massage, education regarding coping skills. Very important to avoid medications causing headache. Taking a good history, asking about medication intake can be the key for the cause of headache. Medications associated with headaches: ACE inhibitors, alpha and beta adrenergic agonists like medications for asthma, amphetamines like ADHD medications, calcium channel blockers, caffeine, ergotamine, estrogen, acid blockers like famotidine, ranitidine, antimicrobial amoxicillin, minocycline, doxycycline. So ask about acne medications. Vitamin A or retinoic acid, usually used for treatment of acne, thyroid hormone replacement, or levothyroxine. In summary, taking a good history and physical examination is the key for diagnosis and management of headaches in pediatrics. Ask about history of trauma, post-traumatic headache, infections, pharyngitis, sinusitis, encephalitis, meningitis. Any infection can cause headache, dental decays and dental infections, epilepsy, anti-epileptic medications or medications in general, even ibuprofen, acetaminophen, excessive use can cause headache by itself. Blood pressure, vital signs, very important to check. Take a detailed family history. Headaches in general or primary type of headaches generally runs in the family that has a strong genetic components and also can skip generations. So detailed history is very important, and this can be the key for the diagnosis. Social history, stress in the family, psychiatric disease, look for any signs of sadness or depression. Metabolic palpate the thyroid, check blood sugar and electrolytes. Neurocutaneous, check the skin for any hypopigmentation, coffee or spots, and neurofibromas. Space occupying lesions, look for occipital headaches, progressive headache, new onset strabismus, a change in behavior, poor school performance. Any sign suggests any intracranial problem, abnormal neurologic examination. Check the joints and skin for any possibility of rheumatologic disease. Again, history and physical examination is the best diagnostic tools in diagnosis of headache in pediatrics. Ibuprofen, naproxen, NSAID, or acetaminophen are the first line and often effective in treatment of migraine headache in pediatrics. Use preventive therapy, natural like Mega Relief, or medications like cyproheptadine, amitriptyline, topiramate to prevent migraine in children who are suffering from recurrent disabling headaches, headaches that interfere with lifestyle. Do not miss life-threatening conditions. Know all the differential diagnosis of headaches. Brain tumor is not the most common cause of headache. This is the end of this presentation. Thank you for listening. This video is only for educational purpose and not intended to direct care of any specific patient. Please consult your physician or the physician of your child for the correct diagnosis and the proper treatment. None of my videos can be superior or an alternative for the opinion of an experienced and licensed healthcare professional. Thank you again.